Unquiet Mind by K. Redfield Jamison. K. Jamison is a psychiatrist. So, what she told is that depression is awful beyond words, sounds, and images. Then, depression is treatable, treatment is simple, episode is curable. I think this is something which last time we have discussed when we talked about uh, good reinventing good prognosis of major depressive disorder. Now, I'll before I go on to the topic, I would like to now kind of briefly touch upon the anecdote which in that book, An Unquiet Mind, which is a very good book. The opening sentence of the book, what she writes is, at 2 o'clock in the morning, I was running around wild in the parking lot of that University of California Medical Center with another colleague. This is a medical doctor. I was running around wild in the parking lot with another colleague. A police car pulled up. What in the hell are you doing running around in the parking lot at this hour? When I answered, we are both on the faculty in the psychiatry department. The policeman looked at us, smiled, and he went back to his car and drove away. This shows now what is the impression about psychiatry in the general public, what they have. When you told that you're in the faculty, he had now like an off smile and said, "Oh, okay, I can understand your behavior," and went back to his car and drove away. So that broadly now shows the kind of a public image what psychiatry has. I think we need to change it at least in the near future. Now, going on to the, I think this slide I have been putting every time. This is the third time also I was putting very consciously, very purposefully. I am putting this slide because during the discussion we are going to a lot of some questions and then sometimes a criticism about some of the studies, and then something is coming up. So that is why repeatedly I am putting it so that especially some of the youngsters don't mistake and then completely throw away evidence-based medicine, RCTs and the naturalistic days. Oh, all these studies are now maybe manipulated or something like that. They don't throw it away because evidence-based medicine is science. There can be some quantification of varying in the purity, but discarding ABM is more than discarding baby with bathwater, which I think we have to be very careful about. Now, when it comes to the evidence-based medicine, RCTs, randomized control trials, and also the naturalistic studies, both together constitute the evidence-based medicine. RCTs, randomized controlled trials, are mostly pharma-driven. These are mainly done by the pharmaceutical companies. Here, a lot of times we keep hearing the criticism when a particular drug or when a particular medication does not work the way it has been, the information it has been given to us. Usually the point is that it's a manipulation by the pharmaceutical companies. It is manipulation by this. That is what they keep talking about. Maybe sometimes, as I told, that the quantification of purity may vary, but let me put it here very clearly. It is the pharmaceutical companies, RCTs, which has given us chlorpromazine. It is the companies which has given us imipramine. It is the companies, the RCTs, done by the pharmaceutical companies, which has given us second generation antipsychotics, fluoxetine, the whole lot of, the entire psychopharmacology is given to us by the pharmaceutical companies. I really see a lot of times there's a criticism, but really I salute the pharmaceutical companies, the pharmaceutical industry, especially from psychiatry, for giving us the entire gamut of medications in the psychopharmacology. I really salute them. It costs a lot. It costs about almost nowadays it costs almost about $1 billion to can get one drug, and it takes almost about 15 years. Not a small thing. Somebody may say that, okay, right, we have our Ambanis and all things, he can put about 20,000-30,000 crores and then he can get some 3-4. No, it's not going to be. It takes 10 to 15 years, and sometimes at the end of it you may not get the right drug. We all know what happened to reboxetine. We all know what happened to agomelatine, something like that. Then the evidence-based medicine, it's also naturalistic studies are also there, that which we have seen study, which is mainly funded by the NIMH, National Institute of Mental Health. But here, surprisingly, study has given us the kind of results in like when it comes to the antidepressants, not very encouraging results. At this point, I was wondering, like we all criticize pharma, but I mean NIMH, how much of funds it has given to like it is spending on ECT, which is one of the very very important treatment in the management of MDD, and also something like lithium. Most of the people talk about lithium being an orphan drug. I don't know how much of it is, but whatever it is, this is very important. Evidence-based medicine. Clinician listens to evidence-based medicine with respect is what I told last time also. The evidence, we are looking for a trustable evidence. That is what is very, very important. And at the same time, here also, this is also one thing which we have to be now more careful about. The patients, the consumers have become on one side more sophisticated. Like like the moment you write something, they go to Google and then get the information. But at the same time, the naivety of the general public about psychiatry, majority of them, they don't know the difference between a psychiatrist and psychologist. That's like sometimes the sad thing about it. But I know it's both the ways. So we have to be more careful also. But now I say that, as I told last time also, time has come that evidence-based medicine also listens to the clinicians for guidance. I even say that you better listen, you must listen to that, so that evidence-based medicine, the quality of it improves. So after that, let's go on to the next slide. This is quick, again, recap of what I talked about in the last two sessions, like reinventing good prognosis, where, right, I broadly talked about major depressive disorder, DSM-3 diagnostic entity, why the lumping together of MDD has to happen, which is neutral to the etiology and then therapeutic benefit. And then like, and we also looked at the morbidity and mortality, and it's almost about 85% treatment gap, which really bothers, which is an important thing. 90% being equally effective, and then we had some discussion on that. Study, we had quite a bit of discussion, especially because the remission rates were very, very low. This is what the surprising thing is, that the remission with the drug citalopram, it's less than 30% around that. High attrition rate, low remission rates, which is a cause of major public health concern. This is what we discussed last time. And actually, it's one of the reasons why I am again coming back to saying that MDD in the clinic with this. Right. Today's topic is major depressive disorder in our clinics. Now, I know some of you seniors may be saying that, Dr. Reddy, we have been diagnosing major depressive disorder all along. I've been diagnosing it from the first day I entered my DPM. I started diagnosing, I've been diagnosing, and I'm treating them with antidepressants and all other therapies. So what is that you're telling me about this MDD in the clinic? We know the diagnosis, we have been diagnosing, we have been using antidepressants, we have been using other therapies, psychotherapies, and then CBT and all things. And then, yes, sir, it's not that you're not using it, but there seem to be some problem. All of us are diagnosing, all of us are using, but then how do we explain this? Such a huge gap here. This is going to be the most important thing we have to. And then when the question comes like this, and then I thought that this would be an interesting slide to present. Doctor's Bhagavad Gita. Don't think that, no, why are you so much worried about this MDD and all things, as you are asking? Don't think of your past patient. Sir, I do think of my past patient because I learned from my patients. I always say that patients were my good teachers. So I definitely think about. Don't think of your future patient. Certainly, sir, I have to think about it, because whatever the experience, whatever the learnings I had from the past patients, I have to see that my future patient gets a benefit of it. I certainly think about it. Just think of your present patient. Very definitely. He's my bread and butter. I have to think about it. I certainly think about my present patient. When you are not there, right? When you are not there, that's almost about now. Like, and I came into this world in 1955. Before that, the hospital was functioning. Yes, sir, hospital was functioning. Before 1955, hospital was functioning. But that time, it's not called hospital, but they were called asylums. Even when you leave, I don't want to leave soon, sir, because I want to leave only after I see a biomarker, very definite biomarker for MDD. And also when I see a antidepressant coming into the market which can help the patient come out of depression in just 3 days. That's the only time I want to leave, not before that. This will function here, right? The patient who is yours today, yes, was some other's patient yesterday. Definitely, I'll be very happy that maybe this patient thought that I'm a better clinician, but not like so much joyful about it to feel about it. And tomorrow he'll be some other's patient. Yes, it's a bit of a concern, but I'm not too much worried about it. To tell you all, we at Asha Hospital, we are about 5 6 senior consultants. We practice at the same time in the same premises and the same floor all day. So this kind of patients, somebody else is coming to me and then going around, it is not something new to me. We are very well used to that. When you think yours is not yours, I think mine is mine. This is responsible for all your grief. I understand. I understand, and that is why I'm coming back to you again and again with the major depressive disorder. And I think last time I even made a mention saying that I'm depressed about depression. So this is about this, and then that is what my passion for this MDT, and that is where I talk about it repeatedly. Right, going back to the subject, MDD in the clinic, as you said, we have all been diagnosing MDD and treating with antidepressants and therapies. Perfectly right, sir. But then my question is, why is there such a big treatment gap? National Institute of Mental Health, the study showed that 85% of the gap. And then there's a WHO, both in 2012 and again 2017, two times. 2012, it said that depression is a crisis. 2017, depression, let's talk. Both the times, it's very clearly told that not just in India, developing countries, even in the most developed countries, there is a treatment gap of more than 60-70%. And very clearly, the WHO mentioned it's not always because of lack of resources. You may say that in India, for this population, we have only about 7 to 8,000 psychiatrists, but in let's say a place like US, for the population of about 35 or 40 crores, there are more than a lakh of psychiatrists. It's not because of, and then more than a lakh of psychologists and then social workers. It's a huge numbers they have. So it's not always because of lack of resources, which I can understand. So there is something else which is happening. Why? That's why treatment gap is happening. That is why I wanted to discuss today. The most important thing is the concept. Are we dealing with MDD, the kind of a conviction which we have to deal with as a diagnosis and treatment? When we make a diagnosis for MDD, we say, yeah, MDD diagnosis, but it's a very heterogeneous group of diagnoses. We can make about 250 subtypes of MDD. Antidepressants, yeah, antidepressants are good drugs, but we know that the study has shown that the response is only in about one third. And the personality of the patient. When the patient doesn't give you show the kind of a response what you expect, oh, this is the personality of the patient. This because of the personality, you can't expect the total recovery. Something like he's a rote rao. He always will be crying. So something like that. So we are diagnosing, but calling it as heterogeneous. We are giving antidepressants, but saying that it's a very low kind of remission. It's a personality. Something. So this is something which is a problem. Now I ask a question, do we treat MDD in a similar way as a physician treats typhoid? Now, some of you may get very, like annoyed when I say that. How can you compare typhoid with MDD? Typhoid is a definite infectious disease, and then now we all know the cause of it, and then like salmonella typhi, and then the definite treatment is there. How can you compare with this? Yes, sir, I know that I'm stretching it a little bit too much, but still I ask the question, or maybe diabetes mellitus. Are we dealing with it with the same kind of a conviction? No, it's not that. Diagnosis, when we make a diagnosis, it's two things. One is the clinical presentation. What are the clinical symptoms it present? And then it gets confirmation with the labs. Fine? That's what usually happens. Whether it is now like in all different branches of medicine, that's what happens in the clinical presentation, and then the labs will come. Then there used to be a very famous neurophysician in Nimhant, Dr. Mani. This is one of his famous quotes. When like a residents go and ask, there's a patient, and then the EEG is showing some abnormal changes like epileptiform changes, and then some spikes and shock waves and all that. Patient does not have any symptoms. This is his standard answer, I believe. If patient does not have any clinical symptoms, go and sprinkle phenobarb on the EEG. So that shows that when the patient does not have any clinical manifestations, your laboratory investigations are absolutely useless and they're good for nothing. Just don't bother about it. That is what the thing he talked about. Yes, to a certain extent, understandable. But then now I come to diagnosis of MD. How many patients present to the clinician with the diabetes mellitus saying that I have polyuria, polyphasia, polydipsia? How many patients really? Absolutely, almost I think I can say that more than 90%. They go to the doctor with some vague symptoms. You get a blood test done and say, "Oh my God, your blood sugar is 300, your blood sugar is 200," and then you patient does not, he says he's very non-specific symptoms. He's got some weakness and nothing more than that. Do we say that sprinkle metformin on the lab report? I don't think. I don't think things have changed. The same thing with hypertension. A lot of times, people with hypertension they do not have any symptoms of. There's nothing like a disease. Not like rarely you have dizziness and some kind of a giddy feeling and all things. Most of the time, it doesn't have. Then you don't say that sprinkle beta blocker on the BP apparatus, sphygmomanometer. Why I'm saying that is that clinical presentation is important, there's no doubt about it, but sometimes clinical presentation may not give us a very clear picture. That is why we are dependent on lab reports. Of course, now like again and again, I'm comparing the medical illnesses with psychiatric illnesses. I know that there can be some problems, but just because a patient doesn't have symptoms, you can't say that I don't treat diabetes. You don't diagnose diabetes. You don't diagnose, no, nothing like that. No, you can't say that, like a sprinkle and all this. So this clinic, in addition to the clinical presentation, other things are also important. Why I am raising this point is that even in major depressive disorder, sometimes the clinical presentation may not be very classical. The patient is not going to come and talk to us saying that, Doctor, I'm depressed, I'm worried, I have anhedonia, I lost interest in all. No, they are not going to tell. They present a lot of somatic symptoms, non-specific symptoms, but we don't have any labs. We don't have any diagnostic thing where it confirms is a diagnosed MDD. What do we do? Then we may make a diagnosis of MDD, but that will be very, very non-specific. We very, very vague. We are not. That is where I said that the conviction will not be there when you make a diagnosis. When the conviction is not there, even the treatment and everything following will be with the kind of a loose end. It's not with a very definite thing. That is why I put this example of typhoid here. So this is what happens. Sometimes even with the clinical presentation not being perfect and then the classical, we do have to make, and then in MDD, how do we make that? Non-specific symptom, somatic, cross-sectional clinical presentation is not very clear. Then how do we make it? Then we have to look at the course of the disorder. I'll come to it a bit later. Longitudinal course and the family history, but DSM-5 does not give any provision for this because DSM-5 clearly looks at the cross-sectional presentation. If that does not fit into the criteria of 2 weeks and then 6, it will be NOS. It will be, when it is NOS, your treatment, the entire approach will change. That is why this is going to be important, which we'll discuss later.